presented by Markus Manz, the head of the Department of Medical Oncology and Hematology here. Developments in immuno-oncology in Hem-Onc.
Thank you, Rolf. I'm aware that I'm the last speaker before lunch, and I'm also aware that you always say Hem-Onc, that's one organ, so you get one slot. And in fact, of course, you are right. However, it's a somewhat diverse organ, and I'd just like to say that Hem-Onc neoplasias are about 1/10 of the tumors, and they range in the top 10 killers still when you look at cancer. And this is the organ we are talking about, so it's a paradigmatic somatic stem cell supported organ system with those various branches in the innate and adaptive immune system, and of course also non-nucleated mature cells. And that can be matched with this cell of origin idea that we also use in the WHO classification, where we say a myeloma most likely comes from a plasma cell. And I think the evidence is very good. There's lymphoma, there's ALLs, T and B, and then there are some mature myeloid malignancies like Langerhans cell histiocytosis and airtime Chester disease. And then there are somewhat more complicated diseases, AML, MDS, MPN, that originate at the top of the hierarchy. So with any type of therapy, be it immunotherapy or other targeted therapy, you would like to, of course, do something to a private alteration in a tumor and selectively target that, and without side effects then eliminate the disease. In Hem-Onc, you could also say if it's not tumor private, it could be at least compartment private, and if you delete it, then you get collateral damage, but you get it in this compartment, and if you're lucky, then the compartment regrows from the hematopoietic stem cell. So that works for all what's downstream. Once you have the target in the hematopoietic stem cell, you have a problem, but you could possibly do an allogeneic transplantation. Now, as we know, we talk about immuno-oncology, and most of the time we talk about checkpoint inhibition, but there's way more, of course. Antibody-mediated, T-cell-mediated, NK-mediated, phagocyte-mediated, and then all these new artificial intelligent designer immune-mediated mechanisms. The immune effectors could be transferred, or they could be activated by mechanisms to get the endogenous system going. Now, what are examples for it? This is antibody-mediated killing, and I'd just like to remind you that, of course, there's also antibody-dependent cellular cytotoxicity, phagocytosis, complement-dependent cytotoxicity, and direct antibody-dependent toxicity that could make the tumor cell unhappy. Then there is what we say T-cell-mediated killing, and this is shown here once more, the tumor with potentially a tumor-specific antigen being presented by a dendritic cell or professional antigen-presenting cell on class 1 or 2, stimulating a respective selective T-cell receptor, getting some co-stimulation through that, possibly some cytokine, and then having a killer cell that would kill the tumor cell. However, the tumor cell can show checkpoints that will not be overcome by the T-cell, and then it will be inhibited. And what has been tried over years is to enhance the enhancers. Actually, when we talk about TVEC, we still try to do that. That was not particularly successful, and the success comes with the inhibition of the inhibitors by monoclonal antibody interference. And of course, it's not only PD-L1, PD-1, but there are a lot of other checkpoints that can be targeted and that are upcoming. Then to the artificial designer immune killing, things that are prominent, of course, are conjugated antibodies, and Michael Weller also talked about it. It might be cytokines that could be conjugated that can be delivered, or chemotherapeutics that can be delivered to the tumor cell. And then there is something new called BiTE, bispecific T-cell engagers, that can activate a T-cell by binding to an element of the T-cell receptor complex, in this case CD3, and a tumor target or tumor selective or tissue selective target, and can then MHC independently activate the T-cell, build a synapse, and lead to tumor killing, so basically not having a conjugate here, but pulling the T cell to the tumor cell or to the target cell and then lead to killing. And a similar principle is achieved by using super-armed single-chain monoclonal antibodies that are engineered on effector cells and that in an MHC-independent mechanism would then kill the target cell. And that's what we call, in most cases, then a chimeric antigen receptor T cell. And then there's another mechanism that is upcoming, that is that every cell in our body is showing to the innate immune system, to macrophages, a don't eat me signal. And one of these signals is coming through CD47, acting on SERP alpha on the macrophage and tells the macrophage not to eat the cell. When the cell is in the process of degrading or when the cell is infected, etc., then this CD47 is downregulated and this signal, this don't eat me signal, is not delivered to the macrophage and the macrophage can be activated. As a signal alone, this is not sufficient. The macrophage also needs a second signal, which usually comes through the FC receptor, could be also other receptors, but this typically comes through the FC receptor that binds to an FC part of an antibody, and these two signals together then would lead to full activation of the macrophage and the engulfment of the tumor cell. So I'd like to show you a couple of examples, just bits and pieces, how these various types of therapy might work. And the first thing is allogeneic hematopoietic stem cell transplantation. It's done over 50 years now. It's about 50,000 per year done worldwide. I think it's the benchmark for any future stem cell therapy in regenerative medicine. But of course, saying hematopoietic stem cell transplantation is insufficient. It's actually stem cell and immune cell transplantation, and that's actually what works. The co-transfer of these allogeneic immune cells that then act in the recipient long-term and fight the, most cases, hematologic neoplasia, causing graft versus leukemia or graft versus lymphoma effects, which are an euphemism for graft versus host disease against hematopoiesis. It's not selective to the tumor, it's against the recipient hematopoiesis, and the threshold for that is lower compared to the threshold for other organs, for the gut, for the liver, for the skin. However, it's a continuum, and acute GVHD or chronic GVHD against these other organs might occur. But it's active immunotherapy, and I think that's nicely summarized here, because if you take down the matching of the HLA types, the less matching you have, the more graft versus host disease you get, and the more cures you also get, until the people then die of these side effects. And that's shown nicely here. Identical twins, allogeneic stem cell transplantation really doesn't help, while when there's mismatches, then the response rates go up. Now, this is one piece where a T-cell therapy is used, and I'd like to come to T-cell checkpoint control. So these are early studies, 2016 already, where CTLA-4 blocking monoclonal antibodies were used in recipients of allogeneic stem cell transplants, and that's showing a vignette here of an AML, and on this side on a Hodgkin's lymphoma, where individuals that got an allotransplant and got a relapse then were treated with checkpoint inhibition, and indeed it was shown that 7 patients of 28 responded with a CR or a PR, and these were exactly those patients that also beforehand had a little bit of GVHD, so there were reactive T cells available. And the question, of course, is this better than doing the classical donor lymphocyte infusions, which would act in a similar way? But that's a possibility, and I think it's nicely demonstrated here that it can work in theory. Now, are there other hematologic malignancies where this might work? And the poster child is Hodgkin's lymphoma, where the use of checkpoint inhibitors in relapsed refractory non-Hodgkin's lymphoma showed over 80% response rates and long-lasting responses. And that was very surprising, and actually it's the best responses that are shown upon checkpoint inhibition, and the pathophysiology behind it was understood later, where it was shown that these alterations in PD-L1 and PD-L2 disomy, polysomy, copy gain, amplification are actually defining features of classical Hodgkin's lymphoma. And I think that also leads to some understanding why in Hodgkin's lymphoma we have these few tumor cells and then this infiltrate of lymphocytes. And this is a characteristic, and that also defines why the responses might be so good. It has been tried on a couple of other lymphomas, and the overall success rate was quite low, despite primary CNS lymphoma, despite primary testicle lymphoma, and also despite some of the primary mediastinal B-cell lymphomas and EBV-driven lymphomas that occur mostly in the post-solid organ transplant patients, and treatment of these individuals with checkpoint inhibitor, of course, then also leads to the loss of the transplanted organ. And that just shows a larger study that was published this year, showing that in diffuse large B-cell lymphoma, there are only occasional responses, and there are also no copy gain alterations of 9p where the ligand is located. And this is a study showing on a few patients with primary CNS and testicular lymphoma that checkpoint inhibition is working quite well. Now, is there also a problem potentially with checkpoint inhibition? Indeed, this is a study from colleagues from Munich, and it's mostly on laboratory and animal models, but there are some occasional clinical reports already that show that in T-cell lymphoma, PD-1 is a central tumor suppressor, and that PD-1 targeting can also accelerate T-cell lymphomas under still to be defined conditions. So there are some reports also in a case of a Hodgkin's lymphoma where then a T-cell proliferation and a T-cell lymphoma in the end resulted. So that needs to be taken into account. T-cell lymphomas are not likely targets, and one needs to monitor for that under therapy. So optimized monoclonal antibodies, there is many, and especially anti-CD20 antibodies have been optimized and went also to the clinics with better effector function. And then there are new antibodies, as for example, against CD38, which is expressed early in hematopoiesis, but then also in mature cells like plasma cells. And in multiple myeloma, anti-CD38 antibodies are coming to the clinic now, and they are optimized in their effector functions. And this is just to show you what's the therapeutic window. CD38 is expressed in hematopoietic stem and progenitor cells at lower levels, and it's highly expressed usually on multiple myeloma cells. And we expect, of course, that the highly expressed antigen is more susceptible to the toxicity of an antibody compared to low expression. And indeed, this is also shown in the clinic in relapsed refractory multiple myeloma. Daratumumab, an anti-CD38 antibody, was used in the clinic in combination with either a proteasome inhibitor or with an IMiD, Revlimid in this case, and it was clearly shown that adding the antibody against CD38 improved progression-free survival massively. One thinks that daratumumab, in a way, is the new rituximab for multiple myeloma, and this was also taken into first-line therapy for individuals that were not eligible for high-dose chemotherapy with melphalan and then autologous transplantation, and also there progression-free survival is massively increased, and currently the trials are running in transplant-eligible patients to understand whether it would add to benefit for the patients. So, as said, this is going into first line and really causes a paradigm shift in these diseases. Now, bispecific antibodies, there's also one frontrunner that is called blinatumomab. It recognizes, on the one hand, CD19, a B-cell receptor complex antigen on B cells, and CD3 on the other side, on the T cells, and brings those two cells together, and then leads to activation of the T cell and death of the cancer cell. And there was a large randomized trial in relapsed refractory acute lymphoblastic leukemia, standard of care intensive chemotherapy versus infusion of this bispecific antibody, and the trial was stopped because it was positive for the bispecific antibody in the survival probability, and then the patients also had the possibility to cross over and go to allogeneic transplantation, so you recognize that the curves coming together again, but this was the reason to stop the trial, and then this was relapsed refractory situation. Now it's also used in the MRD positive situation in first-line therapy, and also there one sees spectacular conversions of minimal residual disease negativity from positive to negativity, and the randomized trials in first line are now running. We used this since 2015. This is commercially available also at the USZ. We used it mostly in the setting of acute lymphoblastic leukemia, also 2 cases of diffuse large B-cell lymphoma. We used it in the relapse situation prior to transplant, but also after transplant, and I got this data from Antonia Müller from the department. We saw that particularly after allotransplant and using then donor lymphocyte infusion and then using this B-specific antibody that brings the donor lymphocytes to the tumor cells, we saw high molecular response rates. And in the other patients, we saw basically the to be expected in the diffuse large B-cell lymphomas. We didn't see any response, and I think that's an interesting point. Here you can see that a patient with a relapse of a B-ALL with medullary and extramedullary manifestations, you can see it here on the PET scan, the medullary manifestations, the extramedullary manifestation. After 1 cycle of blinatumomab, all the medullary manifestations were gone. There was also minimal residual disease, could not be measured anymore, but the tumor formations, the lymphomas, were not impressed at all. So that's the problem of any effector therapy where you rely on a T cell coming to a solid tumor. I think a very common problem. It's difficult to get those cells in, and you get fantastic responses in a lot of places, but not in the bulk tumor mass. There's a lot of antibody engineering going on, also making B-specific antibodies that at the same time inhibit a checkpoint. So you can hopefully bring the checkpoint inhibition therapy to the locus of the tumor and don't have it all in all organs. Also, there are efforts to give positive signals to enhance the enhancers, basically, and bring and activate specifically the T cells. So it seems like there's unlimited possibility to play with different constructs, and we have to see what comes then really to the clinic. CAR T cells, also something that in Hem-Onc now has made its way to the clinic. This is the first reported child with a long-term follow-up here, ready to go to palliative care and then receiving a new type of treatment, these chimeric antigen receptor T cells, and now being out over 6 years and hopefully and obviously cured from the disease. The T cells are taken out from the patient, they are genetically modified, equipped with this new receptor and then given back to the patient. And this was then done in relapsed refractory AML and with amazing good overall survival, which led to approval of the first product for relapsed refractory ALL up to 25 years old, also in Switzerland. And then the follow-up studies were done on non-Hodgkin's lymphoma, B-cell lymphoma, diffuse large B-cell lymphoma, and others with various products, the one that was used in BLL, but also alternative products. And the outcome was that about 50% overall survival is achieved in relapsed refractory, heavily pretreated diffuse large B-cell lymphoma, progression-free survival around 40%, independent of what product is used. And also those have been approved for clinical use, also here in Switzerland. These are the first patients that were treated at USZ. Again, data I got from Dr. Müller. And we see the expected. And this was the first patient actually that received the product here at USZ. The very first patient, that it wasn't possible to expand T cells from him. he was heavily pre-treated, and the product was shipped, and it wasn't possible to generate CAR T cells. That might be a problem for advanced stage patients, but this was the first one who got it. 9 lines of prior therapy, non-germinal center B-cell, diffuse large B-cell lymphoma, and this is the response rate after 5 and 10 weeks, this is truly amazing, and it's kind of a wonder drug in some cases, and there are also failures to respond. The difference between the two drugs is the co-stimulatory domain that is used for this chimeric receptor, and one will see what in the long run will be the better co-stimulatory possibility. Now, we also try to do research in this area, and we thought that we look for this here, for diseases that are derived from hematopoietic stem cells, so basically the big boy's task with the high likelihood for failure, but nevertheless, this is a challenge, we believe, and it must be done in a way that one takes those T cells, modifies them, brings them back, has an on switch, eradicates then healthy and malignant leukemia-initiating cells, and then remove with an off switch the CAR T cell and transplant healthy hematopoietic stem cells in the recipient, so a replacement therapy, because when the top of the hierarchy is eliminated, then the organ cannot be rebuilt. This should be a movie which I cannot show, but on the left side you would see how these cells can kill, in this case, KIT-positive HeLa cells, while they can't kill HeLa-negative cells, but I can show you here. This is the therapy we have done so far. Human AML in humanized mice that received from the same individuals then human T cells that were genetically modified, and what you can see here is that the acute myelogenous leukemia that is engrafting in the mice, you can see it up here with the high KIT expression and a lot of cells, is basically wiped out in those animals by these CAR T cells. We have no clinical data and no study is ongoing, but we are happy to cure human AML with human cells in mice, and hope that we can take it to the next level. So as a last point, the checkpoint inhibition of the innate immune system, as I explained in the beginning of the talk, every cell presents via CD47, a ubiquitously expressed molecule, its state to the macrophage that receives via SERP-alpha this inhibitory signal. And this here is the Fc receptor, and this is a tumor antigen. If this signaling axis is interrupted, then the macrophage gets a little bit activated. If a monoclonal antibody is on a tumor target or compartment target and the Fc receptor gets activated, then the macrophage gets activated a bit more. And if both axes are interrupted, then this leads to full activation of the macrophage. And this is clinically explored now by several companies. This is CD47 Inc. that published this last November in the New England Journal of Medicine, where they used exactly this strategy in relapsed refractory diffuse large B-cell lymphomas and gave rituximab, although those patients already had anti-CD20 therapy before and failed to it, plus the inhibition of this CD47 SERP-alpha don't eat me axis, and they show for this, I would say, moderate therapy quite some spectacular responses, also here shown by PET scan. In the future will show how that really then in larger cohorts will work. Of course, there's multiple other tumors that are currently under investigation to be targeted via this axis, and this doesn't seem to be the last one. Last week there was a publication also by Irv Weissman's lab in Nature, where they showed that there's other innate signal inhibitors for the innate immune system that possibly can be targets also in solid tumors, and there's hope that this field really will excel in the future. So overall, in Hem-Onc, we see this ongoing evolution or revolution as in the other fields of oncology. And with this, I'd like to end, and I'm happy to take questions.
Thank you, Markus. Questions to Markus? Yes, Kevin?
I understand that the SIRP-alpha CD47 axis is what stops us eating our red blood cells, or keeps our red blood cells in the circulation. Is there a risk that we'll see catastrophic anemias as side effects of some of these drugs, and what are the strategies to avoid that?
Yeah, actually, that was the area where all this interaction was discovered more than 20 years ago. This is not built for tumors. The system is built for physiology in a way, and the red blood cell, the young red blood cell, has high CD47 expression, and when it ages, it downregulates it, and when it passes in the spleen or the liver, the macrophages recognize the old red blood cell and engulf it and eliminate it, and that's for the physiology. There's other systems where it works obviously the same. There's viruses, pox viruses, that mimic CD47 to keep dying cells from phagocytosis. So that all comes again back to immunology also. And with respect to red blood cells, it's true. They give a starting dose with these, with the anti-CD47 antibody, and there's a little dip in the red blood cells, but then by producing more new red blood cells, this is compensated, and in the long run, this doesn't seem to be a problem in these studies.
Well, then I see no more. There's a question. Okay, John.
So, Markus, now we have blinatumomab. We have CAR T cells targeting the same antigen, both very active, highly expensive drugs. How should we compare these? You know, what will be the future, you think? Can you speculate?
I think what we are talking about is the level of effector strength. You could have a CD19 antibody, a naked antibody, an IgG, what have you. You could have a bispecific antibody, and you have a CAR T cell. And with that, the effector strength will increase. Also, the potential side effects do increase. We have these with CD19. There are these CNS side effects that are independent of cytokine release syndrome that might be due to low CD19 expression on the pericytes. So it's a matter of effector strength. It's also a question on how long you have these effectors on board. Sometimes it's great to have them on board for a long time. Sometimes it wouldn't be so advisable to have them for a long time. Bispecific antibodies have a very short half-life in the current format, at least. So I think there's room for both. In principle, I would think that if one has the choice to have a heat-stable, long-lasting, off-the-shelf, everywhere usable product compared to a customized, individualized, complicated produced product, and if it's equally efficient, I would go for that one.
Yeah. Good, then